I'm Dr. Jean Lyon. I'm introducing the facilitator, Cheryl Blumstrom. But this session is entitled Nevada Safe Staffing Law. What does it mean for Nevada nurses in hospitals? In introductions of Cheryl Blumstrom, the facilitator of the group, she has been a lobbyist for the last 20 years. She's owned her own consulting company since 2001. She's been a lobbyist for NNA. She started out in 2002 as a subcontractor working for the NNA. And then in 2008, she took over as the Nevada Nurses Association lobbyist full-time in preparation for the 2009 legislative session. And she has been full-time lobbyist for NNA since that time. Personally, I think she's an honorary nurse. She really has done us a very excellent job as lobbyist. And she was involved with the staffing bill and represented NNA during the whole process. So, Cheryl, I'll turn it over to you.
Can you hear? No. I don't need this. I'm a lobbyist. All right. I have to be able to speak in groups with or without a mic. So I will speak loudly. Let's start from over here, and I'll introduce our panel. My idea today is that we have a conversation among the people that are boots on the ground doing staffing, either as a chief nursing officer or this young lady on our left who is a staff nurse at Renown Hospital, to talk about the people who actually have to implement what we did in the legislative process and talk about where we've been, where we came from, where we are now, what's working really well, what's not working so well that we need to work on, and where do we want to go in the future? And then I'll talk a little bit about forecasting where I think we're going to go in the 2015 legislative session. Mr. Oscarson, come on up here and join us, please. Come on. No, I want you to come on up. This is James Oscarson. He's an assemblyman from the Pahrump area. And he was the integral player in the assembly on the staffing bill. So he knows this stuff inside out, backwards, and forwards. So if you have the process. Thank you. So good to see you.
You look good.
Excellent. All right. You just made my day.
Glad to be here. Thank you.
So, there you go, James Oscarson. Margaret Cavalli, to his right, my left, is the Chief Nursing Officer at Spring Valley Hospital. For those of you who don't know, Spring Valley is not a bargained hospital. Is that correct still? Okay. So we have a hospital without a collective bargaining agreement. I tried to have a hospital here with a collective bargaining agreement. I have Renown, sort of, but I'm not sure that's your, oh, you do, that's exactly true. Yeah, UMC. So we do have hospital both collectively bargained and not. To Margaret's right, my left again, is Marisa Brown. She works for the Hospital Association. She is the Workforce and Clinical Services Director for NHA. NHA is our partner in all of this that we do. And a lot of the work that we do at the legislature, we partner with them. So we have a very good relationship with Marisa. To her right, Dr. Andy Eisen. You are an osteopath.
I am not.
Not an osteopath, you're an MD.
I am.
Okay, I was thinking you were an osteopath.
I worked at an osteopathic school.
There you go, Dr. Eisen is a Las Vegas native. He might be one of two in the room. He did his medical training at Northwestern University and a pediatric residency at the Phoenix Children's Hospital. Then he came home. Unusual. We need more residencies so that doctors can do that training here in Nevada. Now he's at Touro University, and he is the Dean for Clinical Education. Married to Diane and father to Jonathan and AJ.
That's the important stuff.
That's the important stuff, right. To his right is Dave Tyrell. Fairly new position for you since we've last talked. Dave is the Director of Medical Surgical Services at University Medical Center. Big job, holy cow. So we are happy to have, and are you still the NNA president down here?
Yes, I
The
just
regional?
gave that up to where's Donna
Oh.
Miller.
Oh,
Right there's the new
there you
president.
go. So very good.
You're still a director.
Yes, still director.
Be a director, though,
Yes.
fabulous. To his right is Dr. Teresa Surratt, who practices at the Orvis School of Nursing and does extensive research work into staffing and staffing ratios and staffing committees and how it does and doesn't work from a clinical perspective, and has published extensively. So we get a really good scientific look at it as well. And then to her right is Kristen Peterson, and she joins us as a staff nurse who serves on the staffing committee at Renown Hospital. So those are our folks, and we're gonna need to figure out how to make this work, because we're gonna have to pass it around. I think it's on. Okay. All right. So let's start with Margaret. Where have we been? Where have we come from?
Thank you very much. Can you hear me?
Yeah.
Okay, thank you so much for asking for my participation on this committee today. And I'm glad that I get the chance to talk about how this works in our hospitals from my perspective. And I think that it works in our hospitals when people like ourselves are committed to the process, that we all partake in the staffing committee and really work hard to try to make a difference in our hospitals. For CNOs, it's so important to us. We consider nothing greater in our work life than to advocate for the patient as well as the nurse. So we have a unique perspective where we have to balance the two. However, it doesn't serve us well not to have safe staffing. And I'm a nurse. I've been a nurse for over 30 plus years. I won't say how many. But my passion is patients, and I take care of nurses now, although I don't take care of patients any longer. Taking care of nurses is real important to me. So I need to hear from those who are on the front lines, and if they're not willing to share for fear of retaliation, then that's not going to help any of us make patient care better. So for me, I think that the staffing law has just opened communication avenues, and where I kind of still see some struggles is really just in the understanding of how it should work. So sometimes what will happen is I'll get maybe the piece of paper, as I call it, either an ADO. I haven't received a refuse to work request, but I have had some ADOs. And one thing I really hate to see is that I might get it 2 or 3 days later, sometime after the weekend, next week, maybe written in the incident reporting system, when really what I want and need to hear about the situation is live and at the time. For me, I want to solve the problem as soon as it's happening. And there are a lot of things that we can do as a hospital to help solve the problem when it's happening. You're not by yourself on a boat in the hospital. Many of us can step up to the plate and help you during your shift to make things better, correct the assignment, make sure assignments being carried out according to acuity, moving patients when we need to, or bringing in other people when sometimes maybe your supervisor can't see that. So please let us help you. I think that's been the biggest challenge. Maybe
Margaret,
it's-
what's the ADO? Oh,
Thank you.
An
Oh,
ADO.
all right, sorry. You know, in bargain hospitals, they're familiar with the term assignment despite objection. So that means that I'll take the assignment, but I do want you to know I object to it. And it doesn't help for us, as I said, to know about that after the fact when I could have the chance to fix it. So I would just say, let's go back and tell our colleagues that we shouldn't ignore it, that we need to act upon it as soon as we know about it.
does everybody understand ADO?
At University Medical Center, I serve as co-chairman along with our SEIU, the union, one of their vice presidents on this committee. It's our staffing committee, basically. And a lot of the ADOs and so forth that are put in by people will come through us to be looked at and reviewed to see what we can do to remedy the situation. One of the first line things that we talk to them about is though that the situation should be remedied as it's happening. So as Mark was saying, like real time. It's like there's usually, it's because one person doesn't want to listen to the other one about it or just doesn't want to stand. So you'll have a lot of times, even the managers say, just write it up, just put it in an objection thing and fine. And the person will do a frustrating thing and dump it in, and then it's maybe days before it really gets to my desk. And so one of the things we're pushing for is that it's on real time with these forms, so that we can address it and a lot of times not let things fester out there. Now this committee that we put together, and since the legislation went through and so forth, we enhanced it a little bit, doubled the size of the committee. And so we have like 8 members of the union on the committee, which take in everything from CNAs, floor nurses, phlebotomists are on this committee. And then we have the chief nursing officers on it, probably 3 of the directors are on this committee, HR is on it, so we have representation from all over the hospital. We are currently looking at the matrix that we have and also discussing our acuity system. Because as I like to tell the group, I think a lot of times people like to focus on just one thing. So the matrix says this, or the acuity is this, so forth. And I tell the group, the committee, it says, you know what, it's like a toolbox. I said, you can't build a house with just a hammer. You need other things to work on to do it, all right? Whereas you can't decide on what your staffing should look like just because the matrix says you should have X amount, or just because the acuity is this. You've got to look at a number of different things that are involved in it, and a lot of it is just what is the skill level of the nurse that you're assigning these patients to. You're not going to assign a new grad the same patients that you would assign to a seasoned nurse. So you've got to be willing to be at that point. You've got to look at the whole picture of something and not just go with the flat numbers. So part of it with this committee is to be able to build a trust and be able to have those discussions and to honestly look at the situation and say, what is the thing for the patient with this? What is the safest way to do this and to provide care? And sometimes it needs a little bit of give and take. You know, sometimes you have a call off. Well, sometimes, a lot of times you have a call off. And it just happens, but you've got to be able to flex with it. And in this committee, the big thing is building that trust between management and the union, that we all want the same thing, and that we're all really coming from the same place as far as wanting the patient safety. And we've got to then be able to understand how we get to there, like I said, with the staffing numbers and so forth. One of the first things we did in the meeting was to have everything on understanding the budget and how you come up with the FTEs, how you come up with the ratios in the departments. Because a lot of times from the floor level, there is not that education on it. And I remember back in 2006 when I first graduated nursing school and came to the floor, even though I came from a business background, I didn't have a full understanding of how the FTEs were, how all those numbers came about and so forth. And so, you know, on the floor, you're like, well, why don't we have another CNA here? Why don't we have another extra nurse here? You know, how come, you know, this person called off and bring somebody else in, do the overtime, do this and that. And once you begin to realize that it's not that simple, it's possible, but it's not that simple, you know, then you begin to understand it's not just because to save money. You know, people come to me and say, Dave, I know, you know, you're not giving us an extra person because you get a bonus at the end of the year, how much money you save. And I'm like, really? So let me tell you, I said, we have the transparency website. Go to that website and look at how much I made last year. And I guarantee you, most of the charge nurses made more than I did last year. So it's not about a bonus for me. It's what's available, but we'll sit down and have that discussion. But again, the main thing is, I guess, building the trust, trying to get a clear understanding. One of the things about the matrix going out and where with the union we're having discussions about, well, they feel that we shouldn't be able to put it out without union okaying it. I'm saying it's really not what it says right now. I said I think that we really do need to sit at review to make sure that we're kind of all on the same page with this and where we're coming from. But a lot of times it gets down to the financial aspects of it. You can't put more out there than what you have. You can't spend $12 when you only got $10 and stuff. And that's what people have to understand. The thing is, the key to it is how you allocate that money. what units have what and so forth. And sometimes people have to admit that some units are a little bit heavier than they should be. And other units are, they really don't have, you've got to be willing to share that, we've got to be flexible with that. So hopefully as we build a trust on there, that'll get us more flexibility to it.
Thank you. Christine. You're a staff nurse, so you are on the floor providing bedside patient care.
Yes.
Tell me how that works, how you are released from that duty to go and be on the staffing committee, and then how you bring that information back to your unit.
So I work in the pediatric ICU. I've been there 11 years, and as part of that, I've decided to take more on, and I am now part of the hospital-wide shared governance. A branch from that is the executive board. On the executive board, we have CNA representative, our CNO. There's about 12 people on the panel that sits down every month and looks at staffing occurrences, lifting injuries, CODIs, and we kind of look at the whole picture, and we have everything together to see if there's any correlation between staffing occurrences and the injuries that occur. This is done every month. I know it's the first Wednesday of every month, so I'm not working during that time. I just make time. It's a full day of meetings that we just have. I've only been on it for 6 months, but it's been great just to see the process through the hospital on how everything, the process of the staffing occurrences. We did see a high level of occurrences when I first started, and that's when we had this crazy boom in May of we had over 800 people more visits to the ER. With that, just kind of brought into, the more admissions and the more staffing occurrences. So with that, we never saw any correlations with injuries, but it was nice to see just kind of the whole process of everything. Now down to this last month, we just had our meeting, and we have had no staffing occurrences this past month. And so there was a little lack of communication with the process of it all being turned in correctly. And so, you always want to make sure that that is. We take it to the hospital shared governance to get it out there to make sure that people know how to turn in those staffing occurrences. There is that process, and I feel like it's out there enough that everybody knows how to do them.
How do you bring that back to your unit? What's the flow back onto the floor? I mean, you're over here at this meeting. How does it flow back to the floor?
We, on our intranet, have a link to everything is transparency. We have it on the intranet for our shared governance as well as the executive board. Everything is posted from all of we don't put the actual occurrences on there, but everything is listed there for transparency.
Very good. Okay, Marisa. Yes. The Hospital Association has been working on a series of best practices to deliver to their hospital members around this issue. Talk about that, would you please?
So I've been in the Hospital Association now for about 5 years and been involved in policy and advocacy. And we've battled staffing ratios for quite a number of years now. It's come up in Nevada. And so in this process, we've always been able to talk through how we were going to handle the process and where we wanted to go with that. And Bill has been very active, our president and CEO, in talking to legislators and those types of people to educate them with regards to, what that means actually. So the bill had passed with regards to hospitals doing a staffing committee and having a certain percentage of administrators and bedside staff on those committees. And then 2 years ago, well, in 2013, when the legislation met again, we were faced with the staffing ratios bill, and Assemblyman Oscarson and Senator Spearman sponsored that bill. And so we were fortunate enough to, I think we were fortunate enough to be able to manage that with beefing up the staffing committees, including CNAs on that. And we worked very diligently with the hospitals once the bill passed to talk about what that meant. So, providing some sample forms for assignment despite objection, refusal of an assignment, policies to put in place to make sure that it met the intent of the bill. I think we met a total of 9 times once the legislation passed up through December. And we just recently had a forum for all the hospitals to come to, and we invited Senator Spearman and Assemblyman Oscarson to come, and the room was packed. We had a lot of back and forth communication with regards to how that was going. The best practices that the hospitals communicated on were just ideas that we threw out there with regards to how to keep people engaged in the staffing committees, because that was an important piece. You know, we were hearing that they were inviting bedside staff to come to the meetings, but people weren't showing up, or there was other competing priorities, and so therefore there was a lack of commitment from the bedside staff to attend. So we talked about how to keep people engaged, how to communicate the policies, because in the bill it says that you have to notify your staff, your bedside staff, with regards to when those committee meetings are. You have to open your arms up to invite them to come. Communication and transparency is huge. And there was a lot of ideas that were thrown around with regards to that, and a lot of head nodding going on with regards to, oh, that's a great idea, I didn't think of that. And so just the sharing of that. And then I typed up a sheet that spoke to the best practices and then got it out to all the chief nursing officers. And we just felt it was a really, really great meeting. We hope to continue those types of things, to engage the hospitals in communicating. And I mean, we know with the research that we did at the Hospital Association, because California right now is the only state in the nation that has pass ratios. And when this bill came up and we were talking to them with regards to, you know, what the issues were once the bill passed, it's not the answer. You know, as you said, there's a lot of, I mean, we all want to do the right thing. We don't have, we're 49th or 50th in the nation with regards to nurses per 100,000 population. That presents a problem. The hospitals in California can't meet that demand either. So they get sanctioned, they're having to close hospitals, having to close services, because there's not enough nurses to be able to put nurses into place to meet the mandate of the bill. So I think education is what the Hospital Association is trying to do, to educate the nurses, work with the Nevada Nurses Association in partnership to make sure that you're all aware of what that really means, because it's just not the answer.
Okay. Dr. Surratt, you've done a lot of research. You did a survey preparatory to the staffing bill that we worked on, and you've since done another survey. I presented the results of that in April. I was disappointed. Would you speak to that a little bit, please?
In sponsorship with NNA, there was a survey conducted across the state for those nurses that were working in facilities that were impacted by this regulation. And those facilities are located in counties with a population of 100,000 or more people, and that are licensed with 70 or more beds. And so we estimated that about 7,000 nurses were eligible to participate in this survey. And it was, the request to participate in the survey was sent out via postcard. We had purchased the list of registered nurses from the State Board of Nursing. And all of the nurses that were on that mailing list received the postcard, and also a reminder postcard. And it was a link to an anonymous survey that was done online. The IP addresses were not kept, so we couldn't trace it back to any one person. And we had about 500 responses. That's less than 2%. So unfortunately, with that type of response rate, we weren't really able to identify what the impact of the regulation was in the state.
And then the second survey that we did.
The second survey was much more informal. It went out through communications, through NNA and word of mouth, posted on individual registered nurses' Facebook pages and things like that. And I believe we got less than 45 responses. I've talked individually to staff nurses when I've been out in the community, and there seems to be a fear of retaliation if they were to participate in the survey. Whether that's real or imagined is up to those individuals who work in those areas. But that seems to be one of the reasons why we are not getting a good response to those surveys. I think there's a lack of trust that we can keep their responses blinded, and that there is some pushback within the facilities across the state to really voice their concerns with staffing.
So I'd say we have some work to do, yes? We're hearing really good things at the top and wonderful things at the bottom, and maybe it's in the middle that we have our issue. So let's talk about what could make it better. Absolutely. I'm gonna start over here. I want you guys to back clean up. 5 lines.
No pressure.
No pressure at all.
Thank you. I think that something that we could do to kind of improve that situation that you referred to is on my part to make sure that my staff feels that they can trust me and bring issues to my concern that affect them. And the only way to really accomplish that is to spend time with them. So for me, that means spending time on night shifts, weekends, and really being visible so that people don't feel afraid to come up to me and tell me what they think. And really kind of challenge that feeling of retaliation. So I always like to ask, well, when was the last time that you heard that somebody got written up for something like that? And usually people can't pinpoint anything like that. So that always is a worry for someone like me, because I don't know how to challenge that otherwise. If people have a fear of that, then what we need to do as executives is to continue to communicate with them and spend a lot more time with them so that they feel that they can trust us and tell us what they think. We have done a lot of work at our hospital related to staffing. We developed our own acuity system. We're constantly changing it. We always look at our staffing plan every year, and the nurses are pretty comfortable with how they feel related to their morale at our hospital. So I think that just that overall feeling is kind of what you need to improve the trust.
So in order to improve the trust, how do you flow the information from you as the CNO out to your floor managers and then out to the bedside care people?
I'm glad you brought that up, because I think that sometimes it comes out of me, and maybe my managers hear it and they feel comfortable repeating the message, but sometimes my supervisors on different shifts might not understand the entire process as to how we deal with staffing issues. They don't know what to do, or maybe they think there's nothing that can be done, or they just have been having a feel of frustration related to issues that might be coming up, off and on, that just makes them feel like, I don't know what to do, just fill out the paper and we'll send it forward, when in reality there's so much more that they could do. So I think that myself and my managers need to spend more time with our supervisory level to make sure that they feel comfortable.
Great. Marisa, what's the Hospital Association doing on a going forward basis to make sure that this flow of information happens?
I think educating the hospitals and making sure that because we collect the staffing plans and the policies for staffing committee, assignment despite objection, and refusal of assignment, as well as the staffing committee minutes from the hospitals. Because it's mandated that we need to submit it to the chair for the Legislative Healthcare Committee on 1 year, and then the director of one of the other committees on
Legislative Council Bureau.
Yeah, on the odd years. So we collect those, and I help the hospitals work through some of the things that I see that maybe they could do better before they get submitted. I have to say, I really love what Greg Nelson said this morning about that we need to proactively eliminate the challenges, and we have an incredible opportunity to advance nursing by becoming involved in the solution. And the solution would be for all of us to work together, for nurses to get involved in NNA or NONLs so that we have a voice. I mean, nursing is such a huge entity, and collectively we can get so much more done. So that's what I think.
May I speak to that?
Absolutely.
Just going back to the question about how to get things heard and listening. On our executive board, it was brought to our attention that staffing was not very good in our ICUs at Renown. We just had such a huge population of inpatients at that time. So we decided as a group to mandate call. With that, when we had that call in place, it was for a short amount of time. When it came up to decide whether we needed to keep it or get rid of it, we listened to, and I think that's where what's important is to have a voice on these panels from the staff, from the bedside. We listened to what people had to say, why they didn't like call, what they liked about call. And as a team, my management really listened to what we came back with, of the goods and the bads. And they then, with the help of us and the executive board, decided to keep call in place. And we did make changes to it, made it more department specific of whether, you're taking call once a week or once a month. We had to specifically make it different for each unit. And so we listened to what those units had to say. And I think that we got positive feedback from that. We just now know that we have to take call, and that's just the way it is, but they listened to me. They listened to what I had to say, and they made it more of a work-life balance. And so I think that just is positive feedback of listening to what your staff has to say and making sure everybody's a part of it.
Now, you are the chief officer in your med-surg unit, the director. Before that, you were a clinical director. Describe the difference in the position and how the flow happens from you out to the floor now.
Well, before as a clinical manager, I was in direct contact with my charge nurses. And probably after 6 months in that position, I started having an 8 o'clock meeting every morning with my charge nurses to basically find out where everything was going, what my thoughts were on what we should be doing, get their feedback. And then I hit the floor for like an hour in each unit, and when I walk around, at the time I only had 2 units, but I would walk through and just get a feel for patients and so forth, and the nursing staff there. So it was very direct, easy contact. Plus, my office was in a main hallway, and I always kept my door open, and I always keep a big bowl of candy on my desk. So I had like constant traffic coming out of my office. And you would literally have that some nurses, they'd be just frustrated, they'd come in and sit down in my office, I'd be working, I'd look up, they'd say, just keep working, I just need to rest. And it was strange, it made me feel really good that they could actually come in my office and feel that that was where they could relax at and get their thoughts back together. As a director now, I've got like 8 units, all right? So about like almost 300 staff nurses. I've probably got like 150 per diem nurses on there. So, and then I've got 5 managers that I work with. So it's a lot more difficult to get my message directly out to the grassroots level there. So in the 6 months I've been doing this, I've been really going through and assessing like, how do I really get the message? How do I really hear what's going on? Because a lot of times the message that I get is filtered when it comes to me through my managers. And I had an opportunity this past month to really change the way I do things. One of my managers had to go out on a leave, and I went to go divvy up her department among the other managers. And one morning, my drive-in was my quiet time. I'm listening to my cool jazz station, and I get my thoughts together. And the thought came to me, wait a minute. I know you don't want to do this, so you need to take those units. Take those units, get to know those charge nurses in there, get out in those areas, and get them to know me also, because they really don't know me all that well. So as soon as I hit the office, I called the executive secretary and I said, Chrissy, here's what we're going to do. Every morning we meet at 8 o'clock. I want to start holding our meeting over in this unit. And I want to meet the charge nurses every morning at 8 o'clock. Let's talk about what's going on. Let's see what's happening and so forth. And I'll make my rounds through there. And it was just amazing in a week how different things were. How much people emailing me about stuff, calling me on my cell phone, but all things, hey, I just thought you might want to notice, hey, here's what's going on. Hey, I've got this issue, but here's what we're going to do about it, so I want to let you know. And it really made a difference. And I know for me in my development and in getting in touch with them, I've got to get out there. I've got to get out there. I've got to make those rounds. I've got to touch base with them and start learning who their kids are, what they care about, and so forth, what's important to them, and it makes a huge difference there. So when it comes to the staffing things and so forth, and it's 2 units. It's 2 units. It's 60-something beds 62 beds altogether between these 2 units, and how quickly the staff will talk to me about stuff now, what their frustrations are, and when I talk to them about things, they say, okay, here's what I'm doing, here's the plan, and so forth. I said, okay, good, at least you know about it, and we trust you're doing something about it. And that makes a huge difference in there. Like I said, it's a lot. It's a lot to keep up with, but I think the payback on it, on my getting out there, and sometimes I can be buried in my office with stuff, and I can be kind of reluctant to get out of there and stuff. But it's a discipline I have to do for myself. So I have to look at what do I need to change about me to really change what's going on out there on the floor. And I think in the long run it will pay off, in big benefits.
I agree. Exactly. There's a best practice. Am I
Right.
right? So Margaret, how do you invite people and encourage people to participate on the staffing committee from the floor level?
That's a great question. And the first thing is that we post the meetings throughout the hospital so that people know the date, the time, and they can better plan if they're interested in becoming a part of that. And then on the unit, the nurses who come to the committee are often either chosen by the team members on the unit, or if they don't want to choose someone in particular, then someone will volunteer. And then what we do is cover them so that they can come and join the meeting. We keep it to an hour in length so that people can get away, and we schedule more meetings if we need to, if an item hasn't been covered to their satisfaction, so that we can get it covered. And we just make sure that people know that this is their committee. It's not my committee, although I need it because I need to hear from them. But it's really important for them to know that they are the backbone of the committee. And we post the meeting minutes on our intranet, much like the rest of you do, so that in all transparency, that the whole team knows what's going on from the meeting.
How do you decide when an issue has not been covered sufficiently? Who drives that vote?
The team that has come to the committee. So recently, we decided we're going to look at our acuity system because it didn't cover enough of the departments in the hospital. And so we're like, oh, we don't have one for our new mother-baby unit. So that's got to get done before the next meeting. And we need to have a meeting sooner than our usual planned set of meetings. So we posted that so that individuals would know when that meeting was, and so that we could finish that work on the acuity plan.
Excellent. Another best practice.
I got a lot,
Right.
list of them, yeah, it's great.
So Dr. Isaacs,
Yes, ma'am.
you served with us in 2013. You've heard the panelists here. Is this what you expected from staffing as the staffing bill moved through your house and the governor signed it? Is this kind of what you expect?
I'm not sure how to answer that question in terms of what I would have expected, but I had the honor of serving the legislature last session and sat alongside Assemblyman Oscarson, literally alongside Assemblyman Oscarson in the Healthcare Committee as we had this discussion, and we had a lot of side conversations during that, which thankfully I double-checked today did not get recorded in the minutes. But I think that a couple of things that were very important to us, certainly to me, I don't want to put words in your mouth, but I'll do it anyway, is the idea of, and you had made reference to this in California, the idea of putting numbers in statute of what staffing ratios should be, we thought was a bad idea, because we had to be able to adapt this to different institutions. Different hospitals are not the same. Even hospitals that may be across the street from one another. May not be, it may not be the same. How are they equipped? What kinds of patients do they see? How is the entire facility staffed? A much larger facility actually is going to have more flexibility than a smaller facility. And although the floor for this, for the statute to apply is 70 beds, that's a relatively small facility, particularly in either Clark or Washoe, which are the only two counties in the state that meet that 100,000 mark. There's some interesting language you can find in the statutes, by the way. If something is to be written just for Clark and Washoe, it says counties larger than 100,000. If it's just about Clark County, it says more than 700,000. Those are little tricks that the drafters use to pick on one county, or to identify one county or another without saying it by name. But we thought that idea of building a structure within each facility to design a staffing model that works for that facility was very important. And the other part of that was very important is that if you do that, if you create the structure, then you have the ability to come back and correct it if there's a problem, or to refine it as your facility changes, as the environment changes, as the challenges that your hospital face changes. If that's enshrined in statute, the best you can do is hope that in a couple of years there'll be a willingness to go along with the change that you need without also mucking up everything else in that statute, which is always a risk. So I think the idea, some of what we're hearing about, certainly what we're hearing about from now, I think is great that we're rolling this forward, but it's going to take us some time to get this right. And the fact that we put that flexibility at the institutional level, I think is going to make it a lot easier for us to get to what is right and to keep it right for a longer period of time. Since you gave me the microphone, I'm going to go on one other thing.
Okay.
Your fault. There's another couple of hats that I wear, and the same sort of advice that I give, or not necessarily advice, but the same position that I take, I think applies here. I'm the president-elect of Clark County Medical Society, and we just had a discussion not all that long, some months ago, talking about legislative advocacy and lobbying for the medical society and with regard to physicians. And I posed what was, quite frankly, in that room, not the most popular opinion, which, by the way, is really common from me. And I said, if we can't expect to win our argument if we don't put the argument in terms of what's best for patients. If we try and convince people that they should do something because it's best for doctors, we're going to lose every time, and probably should. But what we need to do is always make sure that we're putting our argument in terms of what's best for patients. And if we can't do that, if we can't define our position based on what's best for patients, we probably have the wrong position. And I think that applies here too when we're talking about staffing, when we're talking about assignment despite objection or refusal for objection. I think it's incredibly important that that always be phrased in terms of what's best for the patient. If you make your argument in terms of what's best for the patient, I think it's going to resonate considerably more with the hospital administration. But if you can't do that, you're probably making the wrong argument. Now, you guys are a much easier crowd to talk to about that than the doctors that I usually talk to. Because, frankly, if that's not your priority, then you probably shouldn't be a nurse. And if that's not your priority, I'm pretty confident you're not sitting in this room. So I think that that's a tremendously important thing. And when we talk about the flip side of this, the challenge of this, people not participating in the surveys, people not forwarding their concerns, whether it's through a committee or directly to the CNO or however, that's when I got to put on another hat. As Cheryl mentioned, I'm the Associate Dean for Clinical Education at Touro, and I'm Associate Professor of Pediatrics, and I teach my medical students, every month I do a 2.5-hour lecture about child abuse reporting, their responsibilities there. And what I say to them is, if you're not willing to do this, then, well, I'll clean it up. Then pack your things and go, because you picked the wrong profession. And there is no one in the state of Nevada, to my knowledge, who is sentenced to be a nurse. You may feel called to be a nurse. I think most of you probably do. But it is a choice that's made, and along with that choice comes an enormous amount of responsibility. And among that list of responsibilities is to speak up when something is happening that is not in the best interest of your patients. And if you fear for retaliation, for one, there are protections in the law that prohibit facilities from retaliating against nurses and CNAs for refusing an assignment on that basis, or for an assignment despite objection when they're concerned that it is an inappropriate assignment. The hospital can't do, they can be sanctioned for retaliating against a nurse or a CNA. But my point is, I don't care. I really don't. Because what's best for your patient has to come before what's best for you. That's the reason that you got into this business in the first place. Nobody goes into nursing for the fortune and fame. You did this because you care about patients. Don't forget that. And if there's an assignment that is presented to you that is not appropriate, for whatever reason, you have too many patients, it's beyond the scope of your training, the acuity is simply too high, whatever it may be, if that assignment is not the best thing for the patient, you have an ethical obligation to speak up. And if there's a systematic problem with the way assignments are being made, you have an ethical obligation to speak up, to say that this is the problem and we need to fix it. And there are pathways to do that. You can even do them anonymously sometimes, send out another survey somewhere, we could. But you need to do that. And so as a physician, I'm relying on you to take care of my patients. I need you to speak up when something isn't right. I need you to speak up when something is not in the patient's best interest.
Thank you. Okay.
I tried to keep it toned down a little bit.
Awesome.
I use no profanity, which is
I
unusual.
noticed.
And now,
Crystal ball time. What do you think is going to happen in 2015? I have some ideas. I want to see if my ideas agree with yours. Please.
Well, if I had a crystal ball, I probably wouldn't be here.
Same.
I guess the first thing I really truly want to say is I did have the opportunity to serve with Assemblyman Isaac. We had a lot of good times. We didn't always agree on everything, but we had a lot of good times. And I think truly his influence, and I'm going to count on his influence going forward for him to call me, and I believe we're good enough friends that I can maintain that communication level with him when there's things that come up that I need him to counsel me on and to give me input. And I think the world of Andy Eisen, and I would appreciate it if you'd indulge me for just a minute and thank him for his service. Thank you. Now, while I'm not nearly as funny as Dr. Eisen is, or have nearly the wit he does, I do have a few things that I've written down, and then I'll get to your crystal ball issue. First off, NNA and NHA have done an outstanding job trying to express and convey the intent of the nurse staffing ratio bill to people. Before any of you walked in here today, I'd just like by a show of hands, how many of you knew what a nurse staffing ratio committee was? Okay, so there's your 45. I was at the committee hearing when those results were discussed. Cheryl, you and I talked about them at length. And it was very frustrating. And I think that through those conversations, what's happened is there's been intranet and internet and all those other kinds of things that have gotten this message out. And I'd like to get a room of 1,000 nurses together and ask that same question and see if they could raise their hand and tell us yes or no.
I would too.
I'd like to do an independent survey where there was no fear or reprisal or repercussion from some independent group where there was no identifiers, like you've tried to do, to ensure that that message is being out there. Senator Spearman and I have had long conversations all summer long, meetings with hospitals, other groups to discuss exactly these issues that you've brought up. best practices are imperative that you share with each other. I think empowerment is probably one of the key things that we got out of some of these discussions. I think you have to empower, when these issues come up, you have to empower shift supervisors, house supervisors, nurse managers, or somebody can pick up a phone and call, and yeah, guess what? Maybe you have to get up out of bed and make a decision, but that happens. That's the reality. Because if you've got a nurse that's filed an ADO, they're not going to be happy regardless of what you do if you continue to make them work like that. And what kind of care is that to the patient? That's really the reality. For those of you that don't know, I have a nursing background, I have a big pharma background, and I have a nursing administration background. So I'm keenly aware of what happens on the floor at big hospitals and little hospitals. This is an age-old issue. When I was right out of nursing school, I went to a hospital to work in Las Vegas. I worked the 7 to 11 or 11 to 7 shift. I had 28 patients of my own to take care of. So this is on a step-down cardiac. They just come off the unit and we had 2 or 3 codes every morning about bathroom time. So I'm keenly aware of the challenges that are faced by nurses, by physicians. I have a lot of friends who are physicians, concerned about their patients and how they're being taken care of. And from an administrative point of view, the FTE issue is always an issue. It's always, how are you going to figure out if you have to call somebody off and bring an agency nurse in? Do they really know the ortho floor? Do they know the OB floor? Do they know these kind of things? You try and match up those things, but it doesn't always happen, guys. It's a reality. There's just no way that those kind of things happen. So we have to work the best way we can, most effective way we can, and in no way, shape, or form, and I have to correct whoever said it, I was not a sponsor of the nurse staffing ratio bill. I was brought in after the big meeting and asked to work with Senator Spearman to see if we could come up with some options, and we were able to do that. There's still some holes. Again, Senator Spearman and I have been working all summer long at meetings like the one that was held with the Nevada Hospital Association, NNA, and other folks, and we're working on those. But I think empowerment's going to be an important time. I think there's got to be something that and I know it's already in legislation, it needs to be impressed upon, or we need to do something that takes away this fear of retaliation, because I think that's really where the pushback is. What's going to happen to me if I do this? And it's unfortunate that it's like that, but we're way past that. We're in the 21st century, guys. We're not where we need to worry about those kinds of things. So if we need to tweak that a little bit, I'm certainly happy to look at that. I think that the response time, again, back to the response time. We have to respond to these issues, not at a monthly meeting, although I understand the review process and all those kind of things, but they have to be responded to and an action step taken almost immediately. Otherwise, we're creating that fear, we're creating that hostile environment, we're creating all those kind of things that just don't work. So we may have to tweak the legislation a little bit, so within 12 hours there has to be some kind of response. I know some of the hospitals in Las Vegas actually have a documented process where they actually call the employee that filed the ADO. They go through this process, and it's all well documented. I'm not sure that there should be some standardized way to do that so that it's administered uniformly throughout. And that's one of the things that we talked about, is the uniform administration of how this works within the hospital environment. We just have to make sure that it's being adhered to. The intent of the legislation is exactly that. And again, I want to go on record telling you today, I am not for mandating nurse staff ratios. I think that's, if you look at the way it's worked in California and read some of the white papers on it, it has not been successful. So I think organizations should be allowed to staff their hospitals the way they see fit. They know the acuities. There's things that they can do to accommodate for influxes of patients if you have a flu outbreak or those kinds of things that happen. There's ways that you have a plan in place to take care of those things. So hopefully I didn't digress too much, and I'm about 2 minutes over, so I'll hurry. The future is going to be very interesting. A lot of things are going to hinge on some of these Supreme Court challenges to the Affordable Care Act. where we're going to go, the reimbursements are going to be, what's going to be allowed, what's not going to be allowed. But for right now, the state of Nevada is in business as usual. We've got additional huge numbers of people who've enrolled in these programs. We've got to figure out how to take care of them. One of my huge issues right now that I'm facing, especially in rural Nevada, since the speaker-elect decided to put me in charge of a rural legislator in charge of the healthcare committee, rural issues are going to be really important. And one of those is network adequacy and network narrowing. And I filed a bill today, or filed an intent to file a bill today for network narrowing and network adequacy. We can now no longer have nurses working in communities and patients going to see those hospitals and those facilities that are in some of these other rural communities, or big communities for that matter, being told they have to drive 120 miles, 200 miles to get services when there are services available right in their backyard. Can't happen. We've got to figure out a way. I've worked diligently with the insurance commissioners and with the medical association. Dr. Eisen, you know some of the conversations that we've had. And so I'm going to work diligently to see what we can do to widen those networks out so people can get care. That in turn creates jobs and other opportunities at some of these other hospitals for people. Crystal ball, other than that, lots of challenges when it comes to how we're going to provide care, just how that's going to be done, and with the influx of patients, it's taxing the hospitals, it's taxing the nurses, it's taxing all those things. Residency programs are something we've got to look at. We need more doctors, we need more nurses, and we've got to figure out ways to do that. And if that's through incentivizing them, through education funding and those kind of things, we've got to look at all those options and see what's available. I'll leave you with one thing, if I may. Dr. Eisen kind of incited me to do this. I have been, this last couple of months have been a little interesting for me. I've spent a lot of time with my father, who was very ill in Scottsdale and finally passed away, but he was at the Mayo Clinic. And I think the Mayo Clinic is an outstanding place for service, but I'll put many of our hospitals in this state up against the Mayo Clinic, because I know the service and the commitment there are from the people here. But they've got a big picture on the wall with the Mayo brothers. And I want to just leave you with this, and write it down or do whatever you want with it. I've tried to find a poster, but they won't give me one because I want to put it in my office for the healthcare committee. And it says very simply, the best interest of the patient is the only interest to be considered. Thank you.
And on that note, we have time for like 2 questions over time. So are there questions that we can help you with?
I was wondering, is there any plan for anything happening in the rural hospitals regarding staffing, or some of the smaller counties where you don't have 100,000 or more people? They still have patients. They still have patients who have healthcare needs. They still need to have, I would hope, the same level of care that you would receive if you're in a large county. So what about the rurals? What's happening there?
Jean asks, what about the rural counties? Those counties under 100,000 and under 70 beds, what's going on with them?
Well, I can probably speak to that because I've dealt with a lot of them and been visiting with a lot of them. And I can speak about Pahrump specifically, Desert View Hospital. 25-bed critical access facility. Services, closest services are located in Las Vegas, about a 70-mile drive, 140-mile round trip. Most of the critical access hospitals that I've experienced and I've been to and visited, I visit a lot of them, have it pretty well dialed in. They've got nurses, they know what they're going to have, they even have contingency plans. Desert View Hospital, for example, when they spoke at that meeting, at the forum, actually do the same thing the big hospitals do. They have their nurse staffing meetings every month. They talk about, they have the assignment despite objections, and they review those and go through them with members of the staff. So while they're not required to do that, I can tell you, I believe a majority of them are already practicing that. Because, let's face it, at some point in time, the potential may be that they have to, that there may be something that comes along. I've encouraged every one of them, as has Joan Hall from the Nevada Rural Health Partners, to participate and practice those good best practices. Rural hospitals are unique, as we all know. There's difficulty in getting staff a lot of times. You've got one nurse that knows the whole hospital, and she's trying to train, and new grad nurses just don't want to go 200 miles away and rent an apartment somewhere that they're not familiar with and have to go home on weekends and all those kind of things. So they have their own set of challenges, and that's probably why, while they're not exempted from their roles, there are some different kinds of things that they can be enforced. But I will tell you that the rural hospitals are in tune, the ones I've talked to.
But did the nurses have the same whistleblower protections in the rules?
Sure, every nurse has that protection. And again,
Under the law.
I'm sorry?
Under the law.
Absolutely. Under the law, any nurse does.
Every nurse does. It's not unique to staffing committees or staffing situations. Every nurse in Nevada has the same whistleblower protection.
That came out in AB 10.
That was like
piece of legislation before, yeah.
2009. It's been in statute for a good long time. We worked on that. And it's absolutely in place.
Hospitals that retaliate against nurses are in that's a bad thing. I mean, that's a really, I don't know how to tell you other than it's just a really bad thing.
Well, it's bad thing, but we all know that proving that is not always.
Well, I don't know of any cases that have come out that needed it to be proved, but if there are, I'd sure like to know about them.
There's your guy.
All I can tell you is I hear a lot of stories. I'm no longer in an acute care hospital as an administrator, but I am a patient, and I do hear stories everywhere I go.
And that goes back exactly to the education process of the hospitals. Large, small, medium, they all need to understand the nurses. And it wouldn't bother me a bit to post something at all the hospitals at the nursing station that if you feel like something's happened to you that you've been retaliated against, here's the number to call. Bureau of Healthcare Quality Compliance would be all over that. They just do not tolerate any of that kind of retaliation towards people. And I don't call them whistleblowers. I call them people who want to practice good quality patient care.
Yes, sir.
It is so refreshing to hear Assemblyman say that the patient is a priority. I have a question to ask you though, or maybe you can help have your committee focus. One of the staffing issues that really affects nursing greatly is the behavioral health patient or mental health patients. And when those patients are medically cleared, having a place to send them, clogs up the ER, or even if they're admitted, that means that we have to take techs to sit with them. And so it would be nice for Nevada to really kind of make that a priority issue.
She's asking about behavioral health patients. Boy, there's a seminar that you can spend days on.
Yeah.
Actually, sure.
No,
What she's gonna take it away from me. I can talk about that. I'll try to be quick at this. I spent a lot of time in the interim since the last legislative session working with Southern Nevada delegation, which includes legislators, representatives of private industry, a whole bunch of folks. And we formed a number of subcommittees. One of them that I helped to lead was the healthcare subcommittee, which in the first meeting became the mental health subcommittee because we realized there were a lot of challenges in healthcare, but if we didn't address the mental health issues, none of the others were going to get solved anyway. And that committee actually put forth a number of recommendations, things that we could do to move forward the mental health system in Nevada. We're particularly focused on Southern Nevada, but frankly, the recommendations are good for the entire state. Every one of those recommendations, save one, has already been forwarded by the Governor's Council on Behavioral Health and Wellness. So that's tied into the Governor's proposed budget, which means hopefully there'll be some dollars for some of those things, but a lot of it's just restructuring the way we do things, bringing the delivery of mental health care to at least a regional level and not a statewide level so that we can customize it to what the various regions may need. And we recognize that the biggest challenge to the mental health system in Southern Nevada is that there's no system. We've got pockets of care, lots of gaps, We have pockets of care, some of it great care, but the integration of that care has been very poor, particularly the connection between mental health care and acute medical care. So a great deal of that has already been moved forward by the Governor's Council. That Southern Nevada delegation is going to continue to move forward to advocate for those things. The one recommendation that has not yet been moved forward, but the Governor's Council is meeting again in a couple of weeks and is very positive on this. They just haven't made a final decision yet, is that regionalization concept, to go from a statewide administration of mental health to a regional one, whether that's 3 regions or 4 regions in the state. That's still sort of up in the air. But all of these other concepts that we've talked about, the idea of not just how do you deal with the patients who are essentially getting babysitting therapy in the emergency department because there's some place to send them, but how do you prevent that from happening in the first place? How do you divert patients so they never end up in the emergency department if they don't need to be there? How do you prevent the application of a legal 2000 rather than worrying about how we take one off? What can you do to avert the need for one? And how can you, even better, prevent people from decompensating into crisis by ensuring that they're tied into care consistently? So there's a tremendous amount of work to be done. It's taken us decades in this state to screw up the system this bad. It's going to take us some time to fix it, but we are taking some of those steps now.
Specifically to the rurals, I can tell you that rural mental health telemedicine is coming. We're going to be able to tie into SNAMs and NAMs and some of the other hospitals and be able to hopefully clear some of those patients. The most frustrating thing you can do is have a 9-bed ER and have 4 of those beds occupied by L2Ks in a small rural hospital. And it happens all the time. And the sheriff brings in a very violent offender who's threatened to kill people and drops them off and says, oh, they're their problem now, see ya, and takes off. That happens every day in rural Nevada, and there's got to be a response to it. I think that we just have to address, like Assemblyman Eisen says, we have to address the cause, root cause, and be able to provide care earlier, interventions earlier for those folks so they don't end up in a crisis situation. I did mental health crisis intervention work as well for Monte Vista when it was one of the hospitals here, so I get that side of it too, and I can assure you that it's something that will be high on the priority list of the Healthcare Committee, and with the recommendations from the Governor's Council and the Southern Nevada Council, those are all great resources and institutional knowledge that we're going to utilize when we're making some of these very difficult decisions. But, ladies and gentlemen, let me tell you, it all rolls around money. It all rolls around the budget and where the budget is and what happens. So please know that we're going to be watching that very closely and trying to do the best we can.
Thank you. Thank you all. We went long, I'm sorry, but what a marvelous panel. This is exactly what I hoped. So let's thank them, please.